So I am really pleased to introduce again this series, Dr. Emily Trittschuh. She's a clinical neuropsychologist with the VA Puget Sound Healthcare System's Geriatric Research, Education, and Clinical Center, or GRECC. And she's an associate professor in the Department of Psychiatry and Behavioral Sciences at the UW School of Medicine. She specialized in neurodegenerative disease and geriatrics throughout her career, and her clinical work and research has been focused on the full continuum of cognitive aging, from dementia to super aging into the 90s and beyond. Since joining the VA, she has developed an additional and complementary interest in the care of older veterans with PTSD and cognitive concerns. And today she's going to be talking with us about managing cognitive concerns in primary care settings, brain health in aging. Welcome, Dr. Trittschuh.
Thank you so much. I appreciate you all joining here today. And I know that depending on your time zone, it's late-ish in the afternoon or later and sort of early evening. So I'm really pleased that you're joining in today. Let me go on and move forward. I don't have anything to disclose other than the fact that my views and opinions are what I will be presenting here today, and they should not be taken as official policy of the U.S. Department of Veterans Affairs or the University of Washington. We have some identified objectives for me to cover and you to absorb this evening. I'm not going to read over these, but the basics are that we want to think about the fact that patients do come to us with cognitive concerns, and what can we do about that? How can we promote healthy brain aging in this population? So starting things off, I actually have to harken back to my talk from 2 weeks ago, which, and also to Dr. Thielke's talk, which was the first week of this series, where you think about that differential diagnosis of dementia versus MCI, which stands for mild cognitive impairment, versus what might be more typical cognitive aging. You probably remember that it's absolutely required for either dementia or mild cognitive impairment that there be some change in thinking abilities from someone's baseline, either the baseline of their young adulthood or a baseline achieved after a stroke, but there needs to be some objective change from that. Also, that change really kind of needs to creep up. It doesn't just happen overnight the same way that a cerebrovascular accident would. And there's typically and should be progression over time. Folks don't get better when they have dementia. And then the critical thing that differentiates mild cognitive impairment from dementia is that those changes in thinking have had a negative effect on independence for activities of daily living, for daily function. I highlight instrumental activities of daily living here because those are typically where we see the impact first. Those are activities like dealing with finances, planning transportation, navigating, cooking, all sorts of more complex tasks that we do need to do day to day to get by. So if all of those have the answer of yes, and there's been a terrific workup, which of course you've been part of, to exclude other causes, dementia often is a diagnosis that's on the top of the list. But what if the first two are answered yes, but the third was not? What do we do with those folks? How do we manage that? And that's what I'm going to focus on today. I had a case from the talk 2 weeks ago, Joseph. I'll just recap really quickly that he was a 66-year-old male veteran living alone in an apartment. He was relatively new to the VA primary care clinic because he had moved to be closer to his daughter. The veteran had been divorced and it was from a spouse of only a few years. His daughter was really the reason he came in because she was kind of concerned, felt like maybe he was not listening to her, didn't seem engaged, and she just had general concerns. His premorbid history, the two most notable things were diabetes and hypertension. Both were reportedly in good control, except that labs were done and both his vitals and his labs were out of range. And so the big question that was initially on the primary care provider's mind was, is he taking his medications? Is he using his insulin as prescribed? At that visit, they noticed that he did not seem cognitively sharp. He was disengaged, and they saw those red flags, right, for the delirium, depression, and dementia differential, the 3Ds. Even did a mocha, that's a brief cognitive test, on which he scored a 25 out of 30. That score is not horribly worrisome, but it also didn't seem quite at what this veteran's baseline was expected to be. They were able to do enough evaluation at that visit to rule out delirium. Depression was diagnosed. I covered this a couple weeks ago. The dementia, though, was kind of a to be determined situation. So let's think a little bit more about what might be indicative of possible mild cognitive impairment in this veteran. We review kind of this idea that there are some changes in thinking that are considered typical in aging. They're not exactly the same for everyone, and people don't notice these changes quite at the same time. I feel like a lot of people notice them a few years after retirement. At first, they're retired, they're great, they had all these projects they want to do, but a lot of times they end up being quite inactive. And then they sort of start to slide. Other times people notice them after an illness or other thing, a stressor going on in their life. Now, the question is are those the typical changes with aging that are just sort of being noticed in an acute manner, or is there something more deleterious going on? Is this possibly a precursor, an early stage of dementia, which is what mild cognitive impairment, the goal to detect it is in case it is that precursor to dementia. So how common is mild cognitive impairment in older adults? I'm just going to laugh here. My little picture is covering up part of my slides for me, so I won't be able to read it, but I'm going to move it. Studies, one lovely meta-analysis that is relatively recent, looked at multiple countries and found that, as not surprising, the percent of folks who have mild cognitive impairment goes up with age. Anywhere from about a quarter of the population, 75 to 79, all the way up to more than half for folks who are over age 85. I found a little bit more of a conservative United States sample, and that said it, even the youngest ages, though, 65 to 69, 8% of people met criteria for mild cognitive impairment. And you can see that percentage goes up, sorry for my typo there, between 70 and 74, but it goes up to 37% for people over age 85. So it matters because of those folks who are over 65 who have a diagnosis of mild cognitive impairment, going over time, a certain percent higher than those who don't have MCI will develop dementia after that MCI diagnosis. But I think you're probably picking up on this. This is not everyone who gets a mild cognitive impairment diagnosis. In fact, really about a third of people who have MCI will develop Alzheimer's type dementia or another dementia over the next 5 years, but 2/3 don't. So let's think about those 2/3. Well, we want to think about everyone, and we want to kind of employ the same techniques and efforts for everyone. But 2/3 folks might not even progress. So especially in those folks, we want to take a very active role. So this is just my little graphic for thinking about mild cognitive impairment. It's a really kind of sort of meant to be a continuum, but it doesn't always follow that arrow. So mild cognitive impairment, especially if new therapeutics are developed, is likely going to be that ideal point of intervention where someone has that increased risk, has markers clinically of having cognitive impairment, and we want really good rule outs for anything else that could be causing the mild cognitive impairment. And, hopefully at some point, if we get a true cure, we would actually shift toward that pre-MCI normal stages where those first biomarkers that indicate dementia will occur are showing up in the brain. We are not there yet, though. So, cognitive impairment, to screen or not to screen. The various organizations and government bodies and whatnot that tells us and gives us directions, they've changed. There's differing opinions. So in 2020, the U.S. Preventive Services Task Force released a report where they argued that for folks over 65 who are living independently and don't have red flags, basically, of cognitive impairment, the evidence was insufficient to suggest that they all be screened for cognitive impairment. And so that was that recommendation. But different from that, we have the centers, I'm going to next jump to the Centers for Medicare and Medicaid Services, who interestingly have detecting cognitive impairment as a required element of an annual wellness visit, or even just in regular routine visits. They even they have a CPT code that's specific to an extra visit if you need one to do a more detailed cognitive assessment and to develop a care plan. But they don't necessarily, they stop short of saying you should test everyone. You're supposed to have any sort of concern, either direct observation on the part of the provider or information that comes in from patient, family, friends, caregivers, or others. So that's a pretty broad group that could provide something that would give you a red flag. I work for the Veterans Health Administration, and our Dementia Steering Committee report from 2016, for which I do not know that there's been an official update, recommends brief cognitive testing, doing dementia screening only if certain warning signs are present. That all kind of doesn't fit entirely with the Age-Friendly Health Systems Initiative, which is what I personally believe in, and that is that to be age-friendly, to engage in the 4Ms care, you really would proactively address mentation in all of your older patients and all of the older adults that come through. And frankly, for anyone that's younger for whom there are red flags as well, right? Does this mean that every single person should engage in a multi-hour neuropsych evaluation? Of course not. But so balancing these things can be tricky. But regardless, everyone agrees that if there are any warning signs whatsoever, some action should be taken. So why is this? Well, probably because cognitive impairment, and especially dementia in the earlier stages, has been historically poorly recognized or completely unrecognized in primary care settings until families bring it up. And unfortunately, historically, it's been brought up when there's some sort of a crisis. It could be behavioral, it could be medical. If Joseph was a different person, it could have been that his daughter maybe didn't talk to him as much, and he had just completely stopped taking his insulin and actually was suffering from a severe medical condition due to his diabetes being out of control. And then she would find him and he would be hospitalized, right? We can see how there could be a crisis there due to an unrecognized cognitive problem. So the last decade and even a little bit beyond that, there's been increased effort to identify warning signs and to use screening tools that will trigger more workup, more evaluation and diagnosis with treatment plans. So the thing is, though, is that not everyone should have the exact same workup. There's no perfect algorithm for what each person needs. So it is still important to really think about what's the goal to be achieved, what matters to the person, to the patient, and what are the tools that will actually meet the particular goal in each individual's case. Whatever our tools are, we want to have sensitivity. We don't want to miss things that are going on. But we also want specificity, because knowing something's wrong but not having a clue what it actually is usually is not very helpful. And of course, we're trying to avoid false positives where we would tell someone that they have a disease or a process that they don't, or a false negative where we tell someone, oh, you're fine, and they're not. That would all be against what we're trying to do as healthcare providers. So a lot of research has, in the literature, is focused on subjective concerns. That would be where the person themselves says, I think I have a memory problem, and they bring it up in their appointment, versus objective concerns. And really, that's more just that something comes out on one of these brief cognitive tests or other types of scales that indicates there's something objectively different or not going well. So I have just 3 patient care scenarios here. I've got John, he's a 74-year-old veteran with chronic PTSDs expressing some mild memory concerns. His wife says that's true. In fact, it's actually really bad. She thinks it's much worse than he does. Or we've got Chris, an 80-year-old who is pretty socially isolated with multiple medical comorbidities and does seem to not be taking medications. She's also lost a lot of weight, and there's no good reason known for that. A third person, Pat, is a 65-year-old running their own successful small business, but they've been struggling recently to keep on top of all the billing, and they are very worried that they're going to get dementia like mom did. And that's all we kind of know there. So did any of you catch these subjective reports of concern? I bet you did. In particular, John and Pat both have, even though John's is more his wife's concerns, they are still there. We're seeing those red flags, and Pat as well. So I think you might find yourself saying, I'm sorry, how helpful are these subjective concerns? What do I do with these folks? Does this somehow help me to know what steps I should do to manage them in the primary care setting? The challenge is that subjective cognitive concerns don't always help too much. So there was a terrific study of over 5,000 patients who are all community dwelling over age 70. And they were asked just a quick little screen, do you have any concerns for what they call SMI, subjective memory impairment, but kind of related worries, right? Any changes in your thinking ability. And then they were objectively screened and tested for dementia. For objective cognitive impairment. Unfortunately, the sensitivity of those subjective concerns was only 54%. That means that 46% of those primary care patients who later screened positive for possible dementia did actually not have any concerns about their memory before that screening. So it's really concerning that we just can't use that subjective cognitive concern as the only trigger point for doing more. So, what in the world is complicating the subjective report? Well, the truth is of course, now I'm not going to be able to say the word, I say it all the time. Anosognosia is a condition that is actually common in dementia, in multiple kinds of dementia, not just Alzheimer's type, but also in vascular dementia and others. And it's basically the non-awareness of self. Folks' ability to perceive their own cognitive changes is usually pretty poor. Another reason could be that people don't endorse having memory challenges because they're embarrassed, they are worried about what a workup might find, or whether people will take things away from them, like their car keys. And so there's many reasons that subjective report may be complicated. I pulled another study that was smaller, where there was just a 2-item questionnaire of subjective memory function. And then they also got more testing. And we saw that the proportion of those in the impaired subsample, those who had a mocha score of less than 26, who had a high level of subjective concern, was actually low. So again, this is a situation where we may be dismissing valid concerns, but we're also insensitive to the actual cognitive impairments in the situation. Another study looked at just not the patient's perceptions of cognitive concern, but whether primary care physicians, their sense of whether there seemed to be a cognitive concern, showed only 61% sensitivity. But when they did pick up on it, there was 86% specificity against a full neuropsychological standard. And when you combined the primary care provider's recognition with something like even as lousy as an MMSE score, it actually did help improve the sensitivity with a minimal loss to the specificity. But this is still not exactly, my goal for sensitivity and specificity is going to be the high 80s and 90s in terms of percents. So therefore, the American Academy of Neurology, their practice guidelines state that for that Medicare annual wellness visit or other routine geriatric care, that one should not rely on a historical report of subjective memory concerns, frankly, from kind of anyone. So let's go back to those patient care scenarios. Who do you think should get a brief cognitive test? Should it be John? There's the subjective concerns that are there for sure. Should it be Chris, where we don't have subjective concerns, but there's a lot of other things going on that are pretty worrisome? Or Pat, who is worried about getting dementia. You know, it sounds like they have a family history, but they're still doing their business. So that sounds pretty independent. This is where I really wish I had you all in front of me in an audience, because I would try to poll. But you know, basically, I think there's good evidence here that all of these folks should get, in addition to being asked about memory concerns, they should be given a brief cognitive measure or other objective ways of obtaining information. So why would we give a brief cognitive test? What's the purpose? Well, really all of the ones that are out there were originally designed to detect dementia. They have pretty clear-cut goals in my mind, and that's to get a quick sense of what could only really be called global cognitive function. Breaking these tests down too much isn't really helpful. You can't really say, yes, someone has a memory problem or doesn't based on 5 points or say 10 points that make up the 30 points. You don't want to talk about where their impairment is, or sorry, where their challenges are. You're really just trying to get a sense of if there are deficits. They're also useful to follow people with identified deficits over time, even in a situation where you're not trying to diagnose something. Maybe it's someone who had a stroke and you want to track and see how they're doing. Are they holding steady? Things like that. In the case of trying to identify cognitive decline early, there are a number of benefits that I've listed here that one could associate with that identification, either of mild cognitive impairment or early stage dementia. I have more on the next page to share. I also think this one doesn't get brought up very often, but is there any reason to question whether the patient has decision-making capacity? I don't mean saying whether they need a guardian or there's some overall full life capacity issue. Can they live alone? I just mean, if you're about to consent them for a medical procedure, you might want to know that they understand what they are agreeing to, especially if it's not an emergency or a life-saving procedure. I pulled this from a recent article from the box 2 in it, and it's just as a much more comprehensive list of different reasons why one might feel that early recognition and diagnosis of cognitive impairment has benefit. So one can come up with negatives as well, though, right? But I do think that these are pretty compelling, and when you ask people about what matters, a lot of these types of things are what come up, right? How to not be a burden for one's loved ones, how to make decisions about one's finances and care planning while one still can. Setting up external aids to help support someone living independently longer. Staying in one's home is often a #1 goal. And then you see at the very bottom, there's studies that suggest that it will delay nursing home admission and very expensive other situations as well. So what makes a good brief cognitive test? Well, it's got to detect something, right? It's not a screen if it doesn't have clear diagnostic meaning. And our tests really don't necessarily have that. We want good sensitivity and good specificity. That's kind of with the detection. Some tests are very good at detecting some things and some tests are not, and maybe better at something else. What also makes a brief cognitive test good is that it's not too hard to administer. That doesn't mean that you can just wing it. Everyone should do a little bit of training and practice, but it can't be too complicated. It shouldn't take graduate school classes like I took. It shouldn't take too long either, right? Nobody has that in a primary care setting. So really, ideally, 10 minutes or less would be great. You also want it to be acceptable to the person being tested. You want them to engage in it. Hopefully there's going to be some things that they do well on, and there may be other areas where they do less well. And that kind of also fits into this reasonable amount of time thing as well. It also needs to be cost effective. The mini mental status examination was kind of the standard until its developers, the authors, sold it to a test company, and they started charging per use, and it became not cost effective for big groups like the Veterans Health Administration to pay for every time one of these tests was given. And so alternatives have been found. So I'm not promoting any specific cognitive measure. I'm just going to quickly, and I am going to do this quickly because this isn't meant to be a talk about how to do brief cognitive testing, go over some really important fundamentals that are due to administration, but also characteristics of these tests. So across all of the brief cognitive tests, giving the test in a standardized manner is what is important. This is the way that we obtain the objective data, and it facilitates crosstalk between providers across time, and allows for useful comparisons, right? And so a really popular test is the MoCA, the Montreal Cognitive Assessment. And I'm not going to read over all of these, but there is a standardized way to administer this. There are some really common mistakes that I have seen made by geriatricians, by folks with a lot of experience. And so even if you have learned how to administer this test, you do want to brush up on it. Let's also think about for whom the test is appropriate. Really, it's only been fully validated for folks over age 55 and only up till age 85. So take that with a grain of salt as well. I have a few more little notes here about test retest and correcting for education that I'm not going to read through, but if you use the MoCA website, there's just a wealth of information there. So on the left here is the data from the original kind of validation sample of the MoCA, and it has some suggestions about what different cutoffs might be. I think you'll see immediately that there was really no discrimination in this sample that was worthwhile between those with mild cognitive impairment versus those who ultimately had Alzheimer's disease type dementia. So that's a real, that's an issue there, as you can imagine. And so on the right are a little bit more recent data with suggestions for ranges where you can kind of have that updated guidance. So for instance, on the MoCA, if someone's a 26 or higher, I think there's a decent chance that that person has pretty typical cognition for age. Of course, the person who is a rocket scientist who's now a 26, that may not be right. The person who has a 25 but only has 6 years of formal education might actually be totally typical for them as well. The next range down would be one where you would suspect there might be mild impairment. The next range down, there's more probable chance that this is cognitive impairment, and 14 and lower is pretty safely indicative of significant cognitive problems. I get asked the question whether the original MoCA and the new MoCA version 8.1 are different. They are the same. They changed the color here, and they added the little caveat at the bottom that training and certification are required to ensure accuracy. And indeed, the developers of the MoCA since February 2021 are reportedly enforcing that there's, I don't know if they're enforcing it, but they are saying that it's required to have training and certification. Only people like myself, who did a full graduate school internship and specialized fellowship, seem to be exempt. And then the irony is that this is the test that people use to figure out whether they should send someone to someone like me. The cost to do the training, I believe, is about $150 still. You register with the site. I think it only takes about an hour. It's just a question of whether you have the funding for this and whether it's worthwhile in your clinical setting. There are free alternatives. I'll admit I don't like them quite as much. One that the VA developed or was developed at the VA and that the VA currently kind of points toward is the St. Louis University Mental Status Brief Cognitive Test. Its original publication was quite a while ago. It's like the MoCA, takes only about 7 minutes personally. And someone who's not doing well, it can take more like 10, just like the MoCA does. It had a really limited research and development sample though, and I don't need to highlight how white, how male, and what age these folks were. You'll also see that the sample sizes for the normal controls was larger, but for the other areas, pretty small. They really decided they wanted to have an education focus when they developed this. However, they made that education focus dichotomous. You're either less than high school education, or you are more than high school education. And then they sort of had a slight correction for that. Just like the mocha, though, you need to use the standard instructions. And there is a little video online that you can watch to do this. And it's a free video, so that at least is available. And they have their suggested cutoffs here, or ranges, I should say. And the MNCD, if you can't quite read it, is an abbreviation for mild neurocognitive disorder. So I'm not going to read over the frequently asked questions for the slums, but I did this on purpose so that you would have them in your handouts. The only thing maybe I want to highlight is that they put in their paperwork, their sensitivity to detecting mild cognitive impairment, and really promoted it as being much better than the mini mental status examination. That's not too surprising. This is a harder test than the mini mental status examination. And I have to highlight that the sensitivity is what is quite high. And that's not necessarily the specificity. You're going to get more false positives with higher sensitivity potentially, and not necessarily as specific a detection. So a little bit more good news, bad news about the slums. As I mentioned, it's free, yay. There's no training required. Well, that's sort of a yay. I mean, it's good that it's free, but it would be nice if everybody would take the time to actually go do the video and read some of the background information, but that may not be entirely realistic. There is a Spanish version. The mocha has, I can't tell you how many languages it has. It's probably more than 40 languages. It has multiple English versions. The slums only has one version in English. The Spanish version is a Puerto Rican Spanish, so that may not be applicable to other folks who have Spanish as a primary language. They just changed Jill, the character in a story here, to be an attorney instead of a stockbroker. And then there's a Canadian version, which I find hilarious, because the only change was, instead of asking about what state are we in, it's what province are we in. And the story that mentions Chicago now mentions Toronto, which I'm from Michigan originally. And anyone who's from Toronto knows Chicago and vice versa. So I didn't necessarily think that was so important. There's no official adaptation for telephone or telemedicine for the slums, although if you want to reach out to me, I've done it for my own uses, and I'm happy to share that informally. The mocha has an official adaptation for telephone and for telemedicine, so that's a plus there. The slums has a fair amount of bias. Most tests have some. In this case, it's more than others, both cultural and socioeconomically, and that's a whole nother talk as well. So, for instance, the Jill story is about how she's a very successful stockbroker, and then she meets a devastatingly handsome man, and she stops working, marries him, has 3 kids, and only when her kids are grown up does she go back to work. So it's kind of it seems very outdated. And so I've joked about how I would rewrite the story, but there is no newer, more modern version. There's also very little published research using the slums, and there's a lot for the mocha. For the slums, I really only found 2 quality follow-up articles. There's one from 2017 where they actually broke down the education piece more and found that what was being called education, or what was thought to be the import of education, was also highly influenced by things like socioeconomic status, occupation, and other demographic factors. The 2014 article I have this picture from here was a nice little 7.5-year follow-up study from an original sample of 533. You can see that a number passed away. Of those who are still alive, 62% actually did complete a follow-up slums. And then they did a breakdown on their trajectories based on what those baseline slums exam categories were, regardless of education. And you can see here just exactly what we know happens in any situation with mild cognitive impairment or any brief cognitive test, and that is that it's imperfect, right? Of those who had no deficits according to their original slums, some of them stayed stable, but 33.6 had some sort of a conversion. Now, maybe you're like, oh, that's what we would expect. But if you go to the mild cognitive impairment, you'll see that 48% actually had no deficit when they were tested again. Many stayed stable, and then some converted. And then of those who were considered to be sort of more in the severe category originally, one person had no deficits at follow-up. 13 of those 23 actually looked only mild at follow-up, and 9 stayed in that severe category. Now, perhaps this is somewhat due to the attrition factor that some people passed away. The folks who were institutionalized might have fallen in that category. There's a lot of variables at play here. But also, we don't really know what kinds of treatments or things changed that might have helped as a result of these the detection that occurred. So back to those patient care scenarios. Let's think about John. So subjective memory impairments, yes. Let's say his slums was a 28 out of 30. What would our next steps be there? I can tell you the things that jump out at me is that he has chronic PTSD. I would definitely be wanting to ask about the symptoms there, especially as they fit with sort of the reemergence slash the syndrome that's sometimes seen in folks with chronic PTSD, where their symptoms change and or increase later in life, to see if that's not having a role. Is he having nightmares? Is he sleeping poorly? That could easily be influencing things. The slum score itself isn't worrisome, but I wouldn't just stop there, right? Some education, definitely a lot that can happen. In terms of Chris had no subjective concerns, and the primary care visit was really obviously not surprisingly consumed with the medical comorbidities and also that weight loss and the medications. So a mini cog was done. There was less time to do a longer test, and Chris scored a 2 out of 5, which is definitely concerning. So the next steps here, even though there's no subjective concerns, I think it's really clear that a lot more workup would be worthwhile, and some careful monitoring. So for Pat, the 65-year-old that has subjective complaints, their mocha was actually surprisingly low. And especially considering what's going on, they're still running their business. So the concern there is, how do we support them and try to figure out so that they don't actually like lose their business? So there isn't something, maybe get a family member in if it's possible to double check the finances. Things could be worse than even Pat's aware of. Also, we probably need to gather a little bit more information. How old was mom when mom was diagnosed with dementia, or when mom's first symptoms started? We would have a very different educational and mental paradigm if mom's symptoms started in her mid-60s versus mom's symptoms started in their 80s, right? That would be kind of a different risk profile. So for all of these folks, I'm going to kind of suggest that rule out, monitor, and evaluate plan, the ROAM plan that I had brought up in the talk on the 3Ds. It applies here as well. And as you probably have noticed, a lot of these cognitive concerns can really be kept in the primary care setting while the rule out and monitoring is going on. Certain quick and extra evaluations may be ordered, but we can kind of do that often in a titrated manner, right? Don't suddenly order everything all at once. Go for the low-hanging fruit and rule things out, so that you kind of then have a better sense of, well, what's making things better, what's making things worse. So let's think about applying this to Joseph. In his case, we have definitely the red flags for subjective memory concerns. We had that mocha that was a 25 out of 30 that seemed low for him. And so at a 6-month follow-up, it was clear that the depression was a bit better. But interestingly, his depression was better, and now he's also concerned about his thinking abilities, and his daughter is still concerned as well. So we want to use the ROAM model, and we want to also include some education about brain health and aging. let's see, I am going to move along a little faster here. Oh geez, and of course I did my little animations here. So let me just pull it all up at once. His repeat mocha was only a little bit better. And it became clear that he was still suffering from insomnia. He had even started taking over-the-counter sleep aids, which often are have anticholinergic effects and can disrupt normal sleep architecture. So maybe that's why the mocha didn't come up more. Maybe we're lucky it's not even lower. And so there's many reasons why sleep can affect health. And I wanted to highlight obstructive sleep apnea, which is quite common in folks over age 65. It can cause fragmentation during the night, but it also is creating a lack of oxygen to the brain, which ultimately and over time chronically can actually cause damage in the brain. The challenge is that not many people who are at high risk of obstructive sleep apnea get tested. And in fact, when at-risk adults are investigated, it was actually found to be present in 94% of the cases from this one study. So in Joseph's case, we don't have a collateral that know whether he snores / stops breathing while he's sleeping. So the primary care provider went the smart route and ordered a home sleep study. He was diagnosed with moderate obstructive sleep apnea. And this is important for multiple reasons. This is a treatable condition. And in my memory clinic, it's the #1 thing that really masquerades as mild cognitive impairment and early Alzheimer's. The challenge is, though, is it can be associated with increased risk of dementia. So let's think about dementia and brain health. You know, we don't have a cure, we don't have good therapeutics, and frankly, we still don't understand exactly how and why some people get dementia, but others don't. So when we think about brain health, we can think about resilience and reserve that can help folks stay independent longer. So those top risk factors, everyone has at least some risk of developing dementia, right? And a risk is just something that increases one's chance of developing a condition. It absolutely does not mean for sure you're going to develop the condition. That's a double-edged sword, though, because you can actually work really hard to reduce your risk factors, and it may not always keep you from developing a condition. Although I can certainly say that if you don't reduce your risk factors, there's an even higher chance that you would develop it. So the top risk factor is age. We really can't change that. Over age 65, the risk of developing Alzheimer's or vascular dementia doubles every 5 years. This is approximate. We can't change our genetics, right? The family genetic inherited dementia for Alzheimer's is an incredibly small % of cases. For the most, like 95+% of cases, there is one sporadic dementia risk allele. It's called the E4 allele, and that's about 14% in our population, at least among white people. So that's not really a modifiable focus either. It's not 1-to-1 though that you'll develop dementia. And so that's kind of just what it is. So we really do want to focus on those modifiable risk factors. A couple of years ago, the Lancet Commission updated their recommendations for dementia prevention, intervention, and care. And so I have their graphic here. I'm going to step through some parts of it. Hopefully you can see this. I know it could seem a little depressing that 60% says risk unknown and only 40% is considered potentially modifiable, but do think the risk unknown, that includes things like age and genetics. And so focusing on the potentially modifiable pieces are what are worthwhile. So not all of these are as modifiable as you or I would like. In the early stages of life, education was highlighted as when one has less of it, you're at increased risk. Well, kids don't, a 6-year-old doesn't have say over whether they're going to school or not. And then at midlife, they highlight hearing loss and traumatic brain injury. I don't know anyone that's thought to themselves, I'd like to have hearing loss, or I'm going to purposely do something that will give me a traumatic brain injury. And then sort of similarly in later life, air pollution has been associated with greater risk of dementia. these things are modifiable, but they're modifiable at the world, regional, and community level. They are public health and public safety issues that really require collective work for policy change. So I don't want to take away from these. We all should pay attention to them, but this is not so much the focus of us in a healthcare system for the individuals with whom we care and provide service. So on the midlife factors, I'm going to kind of go quickly through these, and then if people are interested during the Q&A, I'll come back. I don't think anyone is surprised to know that hypertension and atherosclerosis are modifiable risk factors that increase risk of really all types of dementia, but especially Alzheimer's and vascular types of dementia. Alcohol is on the list as well, starting in midlife as a modifiable risk. Drinking in moderation or less is recommended. It can be a primary or secondary cause of dementia. I think the thing that's interesting here is that a lot of older adults I work with do not appreciate or haven't had any education about the fact that their body has a different body composition with age, less muscle, more fat, and that their metabolism of alcohol has changed. So the recommended drinking limits for older adults are quite different than they are for 20s and 30-something-year-olds. And trying to make this change before you're 65 makes sense, right? 65 isn't some magic number that you can drink all this much up to that point, and then you better cut back entirely. So there's a lot of room for intervention here. I also really recommend that everybody think about querying this carefully, because I think alcohol use did go up during the pandemic, and there's a lot of increased risk for many problems, especially, not just dementia, but stroke, heart disease, falls, head injuries, and delirium. Now, what you get thrown back at you sometimes, and I don't want to throw away, is the fact that in some really good research, here is a meta-analysis of studies that looked at whether drinking increased risk or decreased risk for dementia or cognitive impairment. And when drinking was moderate, and typically wine versus beer or other types, and if people did not have that genetic risk allele, it does seem to possibly have just a minimal benefit. But again, this is in the light to moderate zone, and a lot of folks don't know that they're drinking outside of that. Obesity is also on the Lancet Commission's list. I will say it isn't specifically the obesity, it's the body composition and the way that glucose metabolism changes and insulin sensitivity changes. So framing this more about wanting people's bodies to be able to process and use insulin the best, rather than being about a body shaming or weight-based discussion, sometimes is more productive, right? We want to think about the things that accelerate aging and try to flip them to be the things that delay processes of aging, right? We want to increase insulin sensitivity. We want to decrease chronic inflammation and kind of go at it from that approach. Smoking. I wish everyone had quit smoking by now, but folks haven't. This shows up in the later life portion. Not that smoking can't have significantly negative effects at all stages of life, but I believe it comes up here because there's a fair amount of research that shows that if you can quit smoking in later years, within a few years, your increased risk for dementia has actually dropped back to that of your peers who were maybe even never smokers or quit 20 years ago. So, this in terms of behavioral intervention is super important. Most people don't quit smoking the first time they try. A lot of people quit smoking and then start again, and then they want to quit again. And a lot of people are resistant to it, but there's never a bad time to use good clinical techniques to encourage smoking cessation. I guess that's where I'll stop with that one. In terms of mood disorders, depression is highlighted of the Lancet Commission. There's a lot of suggestions, and I think I brought this up more in my last talk, so I won't rehash it here, but it's worthwhile to treat and monitor depression. What hasn't been shown, what also has been shown is that post-traumatic stress disorder can double the risk of dementia in veteran groups that have been studied. And anxiety has not been shown to have that same connection. So also on the list is social isolation, which sometimes gets conflated with loneliness. I just want to mention these aren't exactly the same. A lot of people are socially isolated, but they don't mind it. They don't feel lonely. And then there are folks who are surrounded by people, but feel very lonely. So it's kind of tricky to get a good bead on this literature. And I won't read through all the bullet points here from these two sources, but I do think about Joseph in this case. He moved there. He doesn't have any friends. His daughter's working. He doesn't see her all that often. And so you want to think about when people are living alone, maybe they've had loss of family or friends, they're new to an area, chronic illness, and hearing loss actually gets linked a lot to feeling lonely and socially isolated. So physical activity, it's more that when people are inactive, they have significant increased risk for dementia. So the flip side of that is let's get active, let's get moving. The challenge is that a lot of the research suggests that you really need to do 75 vigorous minutes or 150 moderate intensity minutes of exercise every week. And that can feel like a lot, but it is a dose response. So I'm going to point at this curve here, and you can see that if you're doing none, it's definitely not great, but just even any increase in your activity gives you substantial improvements up until the point where you could argue actually that there can be too much exercise, and that can be negative as well. So that's a risk for mortality. Studies that are cross-sectional and longitudinal have seen benefits also for physical activity, let me put it this way, for being more physically active, being associated with reduced risk of dementia incidents. The challenge here is that these are cross-sectional. They are often self-report of how active people feel they are, but it is still a pretty impressive, consistent finding to see. Some randomized control trials have been carried out. Those are kind of considered the gold standard. They, while not negative, are not as consistently positive in their results. But the problem is it's really expensive to do these exercise studies. They don't go on very long. And they also are endpoints for developing dementia. It's not like you're like, oh, well, this should happen within a year. You'd have to do the study for 5, 10, 15 years to feel like you're actually sure that you're catching. So diabetes type 1 and 2 are associated with cognitive weaknesses, and faster rates of decline in thinking abilities have been seen pretty consistently in older adults with type 2 diabetes. So it is sort of a higher risk. You can think about it, it's just sort of the later stage version of that insulin resistance that develops and the glucose metabolism challenges. So some of the hypotheses for the mechanisms I have in this slide here, whether it's promoting atherosclerosis, causing microvascular disease, glucose toxicity, and the insulin challenges that can actually interact with amyloid, which is one of the hallmarks of Alzheimer's type dementia. So brain health and aging. As Barb Cochran mentioned, we always want to be thinking about these for all of the patients that we work with. And it's tricky, it's hard to flip one's perspective and the way one talks about health conditions from this Eurocentric kind of Western medicine, disease-focused framework, where we're always just talking about the cause and making the numbers better. And what we really want to do is be more forward-thinking and be thinking about prevention, and then the truly best approach at this point is to think about the person in front of us. What matters for them? What do they care about? How can we help them come up with an individualized health plan that can get them where they need to be in the way that they want to get there? So I asked Joseph, excuse me, and he really wanted to think about his diabetes. He cared about his vision. He did not want to get diabetic retinopathy and have vision loss. So his things that he quickly identified was to try to eat less fast food. He was eating a lot. We hadn't realized that at first. To do some physical activity because he was pretty much completely sedentary. And he was hoping that both of those would result in some weight loss. It was not really his primary concern. When we brought up the obstructive sleep apnea, he agreed to join a CPAP desensitization class, but whoa, was he ambivalent. He thought he would suffocate under the mask, and he really only acquiesced to do the class because of the education that was provided about dementia risk. And here is a little bit of the information there as reviewed in a fairly recent article. But these are a lot of things to work on. Joseph just suddenly changing his diet, suddenly changing his physical activity, trying to lose weight, trying to get used to a CPAP machine. Let's think about what tools are out there that could actually help support this behavioral change. So we typically want to go toward techniques of motivational interviewing and education. And I'll kind of jump to education. I'll start with education first. I should say a lot of the tools that I'm about to review, and here's my first slide, are tools that I've helped develop and I use at the VA, and I've disseminated to other sites. I promise you they're free. I get nothing from it. There are other good alternatives out there, and I'm always happy to share any of these materials for anyone that wants to use them in healthcare or nonprofit educational endeavors. I'll have contact information along the way here to share it. So for instance, one of the things that Joseph engaged in was our Healthy Aging Project brain psychoeducation class. It's just 6 sessions in a row they were each an hour and a half. And there was sort of like the intro class where we talked about behavioral change, talked about setting goals and how to track progress or lack thereof and problem solve. And then there was a wrap-up class at the very end. And then the 4 classes were all focused, were each focused on sleep improvement, getting connected socially, keeping everyone's brain cognitively stimulated, and also increasing physical activity. And you can see that we promote this positive behavioral change by using SMART goals, by having folks monitor themselves and really get a better sense of what they're doing. For instance, Joseph, he really did not realize that he was eating fast food every day, at least one meal. And also through the peer support of the group, but also staff support. The folks have workbooks, they fill out daily health behavior logs, and we've seen some really nice results from that. It's also been run virtually as well. In terms of like kind of materials you can hand out or you can go over with people, we have both a booklet and a brochure version of our brain health and quality of life and aging. It has tips for all these categories. You can even go to the website here and pull those materials down. There's one-sheeters on each of these if maybe only one seems to be something someone you're working with cares about. And also if you're interested in the print materials, that's here. We also are almost ready to get a print bid for a worksheet on brain health and aging. And the idea with this is that you run down some of the health practices that may promote overall brain health and check the ones that the veteran is interested or the patient is interested in working on. And this involves with asking, what matters most to you? Asking, what do you value? And writing these things down can be pretty helpful. So this is the front of the sheet, and then this is the back. So you kind of start actually on the back, and then you come forward to the front, or you can kind of go back and forth between them. And that helps us identify resources. And the folks themselves that we're working with can identify their own resources that we might not have ever had a clue about if we hadn't asked these open-ended questions. So that kind of leads me to the tips for conversations. Think of this as a collaboration, right? It's a collaboration to come up with concrete steps that they can implement and you can support and or provide resources or tools for to improve health practices and behaviors. There's a technique called motivational interviewing that is taught, psychologists all get taught in this area, but really anybody can learn how to do this, and it helps guide your conversation, right? Asking open-ended questions is a start. What matters most to you? Why is that important to you? Providing affirmations, right? Recognizing strengths. You could say things like, wow, you've really shown resilience in the face of change. Reflections, kind of, if somebody says something that's super negative, oh, I could never do that. You can reflect back to them. Now, you just said that you could never do that. And yet you told me that, 10 years ago, you did quit smoking for 5 years. So maybe it's not that you never can do it. It's just that what is it? And then they'll say, oh, it's just really hard. And there you get this affirmation, but you have done it, haven't you? Right. And then in terms of summaries, that's useful kind of sometimes to pull in these elements and link it back to what they thought was important, what they want to do. So that kind of reminds you that we're always kind of listening for what's called change talk. People wanting things, they can do things, they feel things are important, they should do it. And then really listening for what's considered to be commitment language. I will do this. I'm ready to do it. I'm going to try kinds of things. Now, in my setting, I definitely don't always hear change talk. So sometimes we just have to acknowledge that people are ambivalent. I hear that you don't want to start getting exercise. I'm also hearing, though, that it's important for you to not have to use that cane as much, right? So you can kind of think about ways to sort of just make sure that they keep tuned in. Instead of pushing information in front of people like I'm doing to you all now, you want to ask permission for it. If I talk about someone's diagnosis as mild cognitive impairment, I ask them permission to give them some of the recommendations that I've thought of that I thought might be helpful for them. And it's just that small little thing that gives them more ownership and direction in their own care. And you can always come back to conversations at another visit, and ask permission again. I've done that with folks. I've been like, okay, I won't say anything more about it now, but I hope it's okay with you. Is it okay if I bring it up next time I see you? And people usually are like, fine, doc, go ahead. So a little segue here. Who has had someone bring up something in their visit that they think they're doing for their brain health, or that they say they're doing for their brain health, that actually sounds pretty outlandish or frankly, perhaps even downright unsafe? I know I have. And these are a list here. I'm not saying any of these are bad or wrong. I'm just saying that there's variable evidence for these. And some in certain populations could be quite deleterious to someone's health. So for instance, coconut oil was a huge fad a handful of years ago. And in Joseph's case, especially while his diabetes is not well controlled, that could have a pretty negative impact on his general health. Sometimes people promote out-of-pocket brain imaging that will show the imbalance in your brain, and then surprise, they then will sell you really expensive supplements so that they then can do more brain imaging out of pocket to show you how it's slightly starting to correct the imbalance and things like that. So it's really challenging when patients bring these things up. And so that's a hard thing. There's a few different government websites that are helpful for identifying or calling out some of these. Even something like brain games. I want to say I always promote cognitive stimulation, but there are things out there that make you pay a lot of money to subscribe to something that supposedly will fix your early Alzheimer's, and that just isn't the case. There's all sorts of free games available. And frankly, the evidence for brain games and cognitive stimulation is somewhat weak. It's not bad for your brain unless it makes you depressed, but it's definitely not a clear-cut winner when it comes to things you can do to avoid dementia. So when I get these things, my number one thought is, okay, Emily, keep your composure. Try not to have a strong positive or negative response. I try to keep up with obviously I keep up with the medical and research literature, but I also try to pay attention to the popular press. There's just all sorts of things that pop up, and social media kind of can take these and they snowball. And suddenly it seems like it's what everybody's doing and what everybody should be doing. I do try to show rather than just telling when providing education. I do really miss being in person doing feedbacks where I actually like draw graphs and pictures and, pull things out rather than just sort of talking at people. And that inverted U for how to show where moderation is, or where the ideal sweet spot is, or how even just a little change can make a big impact when you're thinking about, say, about that J-shaped curve for exercise. I also think where it's a really important job if we can help provide guidance to folks on where to find reputable information. No matter what across the board, I say if they're making big claims like fixing, reversing dementia, and oh yeah, they're asking for big money too. I'm not saying it's all bad. I'm just saying you should be suspicious. And this is all hard, right? Because we're doing all of this, and yet at the end of the day, we don't want to squash hope. We want people to feel their own agency, to take control of their own things of value to them. And for most people, their health is a high value situation. So, I'll just come back to Joseph here at the end. As I mentioned, he did do the happy, you get it, class. And he even made a friend in the class. And then there was that one week where there was a special focus on trying to make social connections and even just like small talk and monitor how often one did that. How often do you smile at people? How often do you say hello? Have you called that friend lately? Or, have you talked to your sister lately? And he even managed to make a friend in his apartment building. And that was great too, because that was someone who kind of ended up, that person didn't go on walks with him, but they kind of held him accountable because they seemed to notice, oh, Joseph, I noticed you didn't go out for your walk yesterday. Was that rain too tough for you? I made jokes like that. So there I jumped ahead. He did start walking daily, not very far at first. I don't even think it was a half mile. So it was like a few minutes. But he was doing it rain or shine, and he actually built up, I think he's still doing it, to going anywhere from 1 to 2 miles every day. The nutrition was revamped dramatically. As I said, he just did not realize how much fast food he was eating, and importantly, how much money he was blowing on fast food, because it seems cheap in the moment, but it really does add up versus doing thoughtful grocery shopping and meal planning. And so his health in terms of nutrition really, really changed. There were objective markers of this change, but really was that as important. The A1C was lower, his blood pressure that he started tracking more often was improved. For him, he was happy. He didn't have as many sort of foggy feeling out of it periods, likely due to his improved glucose control. He did lose weight, but he did still need a CPAP, and he actually was able to tolerate it for his obstructive sleep apnea because less pressure was needed, and so he was able to do that CPAP desensitization class. I actually think he had to do it. I think he did the class twice. The first time was not as much success, and then the second class was more successful. And as a result, he endorsed more energy, better sleep, which were all things that were of importance to him. So that is it. And I'm hoping I have timed this well so that I can talk and answer questions. But I really thank you all for joining today and considering especially this mentation piece of the 4Ms framework. And also in your, you should probably jot down if you are interested in the print materials. This is Julie Moore's email address. She can help with those. All right. Now, how do I get questions? Let me see here.
I have a question already. Lorraine is saying she works with very old geriatric people and thinks when people realize they are losing their memory and losing their sharpness, it's really hell for them. When they don't realize their problems, it is less worrisome. She says her own mother kept saying, I'm losing my marbles and I don't know what to do. Once she couldn't understand, she was losing it. Her stress was improved. My stress went up to keep her safe. What a conundrum.
Yeah, No, it really is. And sorry, I somehow have just messed up my slides here. Yeah, that's really common. That doesn't make it any easier for the person who it goes through the period of, it's often a very rational concern at first and worry, and then in the earliest stages sometimes of sort of losing the connection with it, it's more of an agitation and anxiety that just sort of gets, things get repeated. I'm losing it, I'm losing it. Or they don't even verbalize that anymore. There's just still this agitation at times. And yes, when folks hit more moderate stages, maybe that decreases. But I'm sorry, Lorraine, exactly right. Your stress goes up as she is less aware of her own weaknesses. And that's pretty normal, but it doesn't make it easy. I think I think if someone knows that they've been diagnosed with a memory problem earlier on, I sometimes work with them to sort of just kind of have a little mantra like, I have a memory problem. You know, my memory's not that great. I have other things I do well, but my memory's not that great. And to kind of just have that, as much as they can accept it, to sort of be just part of who they are, and that they have other skills and other cognitive strengths that kind of can sometimes help through those initial phases.
So Julie said that you mentioned there are government sites from reputable sources. Could you expand on what these resources are? What might be some of those government sites?
Yeah, I would have done a better job at putting them actually in the talk, except that the government doesn't seem to spend money on creating short web links, right? So one, for instance, is through the NIH.gov website. You kind of have to follow along. There's like a health section, and then there's a way to go to what they have, education for providers. And then there's even like a digest within that calls out some of the fads and / potentially predatory kinds of things that are out there. So of course, I try to recommend the government websites as a government employee. I think sometimes though, because of the mechanisms it takes to get things agreed upon among and within such a large entity, and the hesitancy to putting something out there that might not be 100% correct all the time. I do think that the Mayo, I think most folks have heard of the Mayo healthcare system. The Mayo website has pretty darn good information. Cleveland Clinic has some good information as well. I would definitely say that a lot of the universities that are affiliated with Alzheimer's research centers also have great information. So the University of California, San Francisco happens to have some sections on education that I like. In terms of calling out scams, the FDA does have sections on this. What's difficult with that is that they only comment on things that either had FDA approval and it's removed, or people that applied for FDA approval but it was rejected. And so that doesn't cover all of the things. There are certain supplements and brain games that never applied for that, and therefore they're not called out. Does that answer the question a bit? I hope so. It's not an easy one.
I think the CDC also has some healthy aging.
The CDC does too, and I love it. I think because of COVID, know your audience if you can, because there's a certain percentage of folks who very much suddenly now distrust everything from the CDC because it didn't necessarily fit with their beliefs or their systems of information. So I still promote it, but I do sometimes think about, helping people talk about the places they get their information from, and then trying to guide that towards places that I know are more reputable. Anything to do with the health improvement, sort of this John Hartford Foundation and age-friendly systems of care. That's pretty nice. What else do I go to? The Alzheimer's Association is not a bad site. They're not going to call out bad products. And, you know, there's some influences there sometimes. Most of their caregiver support information is very strong, and just sort of basic disease information is strong. Oh, here we go. How closely are memory loss and executive functioning tied? Does memory decline mean weaker judgment? I would like to say that, I want to emphasize that memory loss and executive function can actually change very independently of each other. That is to say, though, that not everything in our world that we need to learn is presented to us in an organized fashion. So if someone gets information that they need to learn, but it's disorganized, their memory might be fine, but if their executive function is poor, they won't be able to organize the information to learn it. That also can go vice versa. Someone can have a really, really bad memory, but have good executive function, and they can do an amazing job of setting up systems in their home and in their banking to basically correct for significant memory problems. There's a fair amount of research that shows that the change from independent living to more dependent care is less reliant upon memory loss and more reliant upon a certain threshold being hit in decline for executive function. So it's much harder to teach people or create systems to support those with significantly impaired executive function.
And I just wanted to mention that Dick Stewart, who asked that last question, is going to be talking with us next week about end-of-life care. So great that he's here today. Any other questions from the audience? Dr. Trittschuh, you talked about, you know, like working through the VA system. Do you have anything more to say about people who are concerned or families who are concerned about some of these early signs? And you mentioned the wellness visits. So is that the place to perhaps raise these concerns at the annual wellness visit with their primary provider?
Yeah, and you know, it's a tricky thing, because if you schedule your annual wellness visit, they usually will say, do you have any specific concerns? And I've had it happen where I actually did bring up a couple different things. They're like, oh, well, that can't be your wellness visit. That needs to be a problem-focused visit. And I always find that kind of confusing. I think it's more an idea that of the amount of time that they block for the different types of visits. So I am in no way saying don't bring up concerns when you make those appointments. But think about it. If you have a bunch of concerns, don't just show up at the annual wellness visit with 10 and the provider thought you were just doing a quick check of your blood pressure and, you know, things like that. So I do think communication is important. So that annual wellness visit is where the red flags can be picked up on, or sometimes someone offhandedly mentioned something, or someone didn't want to bring it up to the scheduler. But if you already know that you've got a few things ahead of time, I think it's just worth calling in and making the appointment. And especially if you have good, you know, healthcare coverage is something I absolutely am not, I have no expertise to talk about other than my opinions about the challenges of healthcare in our country. But I do think that one should use the healthcare coverage that you have. I often work with veterans who feel like, oh, well, other vets need this more than I do. And I'm like, well, yeah, there are veterans who have lots of problems, you know, more things on their list, but that doesn't negate your need for good care and your appropriateness to come in. So I think that, again, this is about this empowerment and having folks have their own agency. I also think that it's important to remember that with all of this, these risk factors are often higher in a lot of marginalized groups and minority groups for lots of different reasons. But the one we don't want to be party to is that they don't feel they're heard or welcome in our care settings. And so doing everything you can to erase those barriers that we often don't even know we've set up, right? If your intake questionnaire only says male or female, well, you've just erased a certain percentage of the population who either is transgender or non-binary or intersex. And so just really thinking about how we present ourselves and show ourselves to be open to all is important.
Okay, well, it looks like we don't have any other questions, so I'll just say thank you. This is a topic we've been really anxious to hear about because it's sort of that subtle beginning kinds of stages and what do you do and what's involved. So really appreciate this, Dr. Trittschuh. And folks, we'll see you next Tuesday, same time, same place. And thanks very much.
Thanks, everyone. Appreciate it.